Hey, it's Moses here from StudyRx, where I share my notes with you in order to eliminate the progression of the forgetting curve. The simplest definition of the forgetting curve is that it shows how information is lost over time when there's hardly no attempt at all to retain it. If you're new here, click the big subscribe button. All the links and resources to everything that we cover will be located in the description below. So let's jump into it. So let's start off by defining congestive heart failure. This is known as a progressive abnormality in cardiac structure, or a ventricle with poor fill or ejection with blood. Now, what is the origin of this disease? This is termed as etiology. There are two dysfunctions. One is a systolic dysfunction known as heart failure with reduced ejection fraction, also HFrEF. As a reminder, ejection fraction is the amount of blood that is pumped from the left ventricle with each heartbeat. HFrEF is an inotropic abnormality. Inotropes, by the way, are agents that alter the force or energy of muscular contractions. Here's some important terminology to recall about inotropes. Negative inotrope agents decrease the force of muscular contractions, while positive inotrope agents increase the strength of muscular contractions. HFrEF is often due to a myocardial infarction, which results in a lowered ejection fraction of less than or equal to 40%. Cardiac infarction is also known as a heart attack, and this occurs when a portion of the heart is deprived of oxygen due to a blockage of a coronary artery. Coronary arteries supply the myocardium, which is the heart muscle, with rich oxygenated blood. The second is a diastolic dysfunction, and this is known as heart failure with preserved ejection fraction, also HFpEF. HFpEF is a compliance issue in which the ventricles don't relax as they should, and they stiffen primarily the left ventricle. This will present an ejection fraction equal to or greater than 50%. For the pathophysiology, we are going to be observing the disease state and describing the biological organism. For systolic heart failure HFrEF, we're going to focus on the RAS system neurohormonal model. When a patient has an event such as an acute myocardial infarction, an MI, this will decrease cardiac output. Here are some examples: angiotensin II, norepinephrine, aldosterone, natriuretic peptides, arginine vasopressin, endothelin peptides, and pro-inflammatory cytokines. So as we can see, the progression of heart failure is facilitated largely by neurohormones and other factors such as autocrine, paracrine, which work via cell-to-cell communication, and they alter each other's behavior. For diastolic heart failure, HFpEF, I'll mention this again. We're focusing on myocardial stiffening in that left ventricle. Next is epidemiology. This is where we study and analyze patterns, causes, and effects of health and disease conditions in certain populations. Heart failure instances cost to the United States are roughly $34.4 billion annually. Every year, there are 550,000 new cases and over 250,000 deaths. Cases of heart failure are the most prevalent amongst the elderly. 75% of the hospital admissions for heart failure are for patients over the age of 65. For prevention and screening, we're going to focus on identifying and modifying the risks. The patient's diet is going to be one of them. Hypertension, and as a quick reminder, there are two different stages for hypertension. A typical hypertension patient would present with a systolic range of 140 to 159. Or a diastolic range of 90 to 99. There's also dyslipidemia, which is an abnormal amount of lipids in the blood. If the patient is diabetic, they have to control their diet. Everything I've mentioned relies heavily on what the patients consume on their day-to-day lives. If the patient is a smoker, that's also another risk factor to add to all of this. So it's crucial that we assist patients in smoking cessation, which means to quit smoking or withdraw from nicotine. The next risk factor is going to be practically the same, but I do want to mention a few differences that I've added. One is coronary artery disease. This is when major blood vessels supply our heart with blood, oxygen, and nutrients are damaged or diseased. Then there's chronic kidney disease, which is also called chronic kidney failure. This is termed when a patient is gradually losing function in their kidneys. Our kidneys filter wastes and excess fluids from our blood, which are then excreted via our urine. When chronic kidney disease reaches an advanced stage, dangerous levels of fluid, electrolytes, and waste can build up in our body. And don't forget a buildup of medication as well. My next risk factor is going to be cardiotoxic medications. Cardiotoxicity is the occurrence of a dysfunction or damage in the heart's biological cells and tissues. A few classes of examples cardiotoxic medications are anthracyclines, tyrosine kinase inhibitors, and tumor necrosis factor alpha inhibitors. Cardiotoxic medications make the heart weaker. A weak heart will not be efficient in pumping or circulating blood throughout the body. For history and physical exam, there's going to be a great amount of dyspnea. A quick way to remember dyspnea is SOBO, which stands for shortness of breath on exertion. This is a term used to describe difficulty breathing when the patient carries out a simple activity like walking upstairs or going to the mailbox. Then there is orthopnea. This is termed as a shortness of breath that a patient will experience when they are lying flat on their back. For the physical exam side, cardiologists will possibly be on the lookout for rales, which is crackling of either one or both lungs heard via a stethoscope. Peripheral edema, S3 gallop, which is a rare heart sound that occurs after the typical lub-dub sounds, which are S1 and S2. So as an FYI, S3 is associated with heart failure. There's also cardiac remodeling and poor cardiac output. For tests and procedures, diagnosis should be made clinically with laboratory data that is suggestive of the patient's complications. Some of these tests may include a complete blood cell count, CBC, also serum electrolytes, which include calcium and magnesium, renal, hepatic, and thyroid function tests, urinalysis, fasting lipid profile, A1C, and lastly B-type natriuretic peptide, BNP. Now, after researching BNP, I found it interesting how knowing these levels are helpful in acute settings. However, the use of BNP-guided therapy in chronic heart failure is not well established. So, why are BNP levels helpful in the acute setting? Well, they help cardiologists differentiate the cause of dyspnea. Cardiologists will more than likely rule out heart failure if the patient has a BNP level less than 100. The reason why is because most dyspneic patients with heart failure will present with a BNP of over 400. So what is BNP anyways? Well, from what I've learned, BNP is a hormone produced by the heart. It's a 32 amino acid polypeptide, and more specifically, it's secreted by the ventricles of the heart when there is excessive stretching of the cardiomyocytes, which refers to the heart muscle cells. Another test a cardiologist might order would be a chest x-ray. They're going to be looking for an increased heart size or vascular redistribution with edema in the lungs. In procedures, an echocardiogram will be the most useful test. And the reason why is because an echocardiogram determines the type of dysfunction the patient may be having. Some examples are left ventricular ejection fraction, which is diastolic, right ventricular dysfunction, also the size of ventricles, thickness of the heart's walls, and any valvular deviations. In special circumstances, cardiac MRI may be considered. One of these may be the suspicion of cardiac sarcoidosis. Sarcoidosis is a disease that leads to inflammation usually in our lungs, skin, or lymph nodes. Endomyocardial biopsy should not be performed routinely. It's only for special circumstances such as giant cell myocarditis. And this is a rare issue that is defined with inflammation in the myocardium. There are two common systems that cardiologists may use when confirming the diagnosis of heart failure in patients. For this part, we're going to characterize the patient via their signs and symptoms. The American College of Cardiology and the American Heart Association, ACC, and AHA has a staging system. Stage A means that the patient is at high risk for developing heart failure. Stage B, a patient will present with structural heart disease, but no heart failure signs or symptoms. Stage C, the patient now has both structural heart disease and heart failure symptoms. And for stage D, the final stage is termed refractory heart failure. Refractory heart failure means that despite maximal medical therapy, while at rest, the patient is experiencing symptoms. Now there's also the New York Heart Association functional classification system. Notice how I mentioned classification and not staging. Class 1 means that the patient has no limitation of physical activity whatsoever. In Class 2, the patient now has a slight limitation of physical activity. In Class 3, the patient now has a limitation of physical activity. And finally, Classification 4. This is when the patient is unable to carry on physical activity without discomfort. First, let me say a few things on non-pharmacological treatments. A few of these examples may include cardiac rehabilitation, which according to the ACC, cardiac rehabilitation consists of 5 components. One is having a healthy diet, then there's regular exercise, stress reduction, medical therapy, and smoking cessation. Fluid restriction is another example. The patient will have a maximum of 2 liters per day from all sources. There will also be a dietary sodium restriction of no more than 2 to 3 grams of sodium per day. We're going to avoid medications that can exacerbate heart failure. Commonly used drugs that can accomplish this are metformin, dipeptidyl peptidase 4 inhibitors, which is DPP4 inhibitors, or gliptins such as sitagliptin, selective and non-selective COX inhibitors such as celecoxib, and a common non-selective is ibuprofen, non-dihydropyridine calcium channel blockers like verapamil, and lastly class 1 and 3 antiarrhythmics. Here's a neat way of recalling a few class 1 and 3 medications. For class 1, we're going to have DQP, which stands for double quarter pounder, and these medications are disopyramide, quinidine, and procainamide. As for class 3, SAD stands for sotalol, amiodarone, and dofetilide.